Okay, yeah, we're a little bit early. So I'm sure people will be coming in as I'm talking, which is totally fine because the beginning of it is not really important. It's just sort of about me, which again is the least important thing. But this is me. These are some of the disclosures I have. Basically, these are the people we do work in terms of clinical trials with, and I also serve on a couple of panels. No big deal. There's usually a quote bad slide, but these are the folks who are trying to get shots on goal without totally understanding the disease process. So they're all taking a shot in the dark because they have, usually because they have family members afflicted with Alzheimer's disease. So a lot of them are to be encouraged, and they've had a lot of failures, but we're going to actually focus on more of the successes today. So what we're going to do is we're going to talk about the background of Alzheimer's disease, and then really talk about aducanumab and the accelerated approval, which Medicare currently refuses to cover outside of clinical trial. But since they've refused to cover, a couple of similar drugs to aducanumab have now met merit, and they look like they are really positive. So it looks like the aducanumab mistake was Medicare's. Medicare made an error in not covering aducanumab, and we'll talk about sort of where we're going from here. Okay, so the background. Now, this has not changed in the last really 30 years, I would say. It looks very complicated, but Alzheimer's disease is due to amyloid that gets cut, processed, and this protein fragment gets cut out of a bigger fragment, and then it sticks together into these balls, and lines of change would then further aggregate into these neuritic plaques. This is a marker of the disease. Alzheimer himself drew these plaques, and we don't know exactly why, but somehow when amyloid forms, intracellular tangles created by another protein form, and that again is like the second hallmark of the disease. That produces neuronal death and symptoms follow. This looks really complicated, but really it's not. It's amyloid causes tau, which causes neurodegeneration, ATN. And that's kind of what we see here. We see amyloid clusters outside of nerve cells, these plaques, and those are creating, or they're very associated with, tangles that form inside cells. Here's a tangle within a cell that is no longer present. The cell died. Here's a tangle forming within a still living cell, but very likely very dysfunctional cell. And here's a healthy neuron just to compare. We now have ways of measuring the disease. So people who are alive can be injected with something that goes into a vein. The heart pumps it around the body, and the ligand sticks to the amyloid, to this stuff, okay? And really to this stuff, to fibrillated long chains of the amyloid, and it becomes positive. So visually, you can see that this looks very different than this one, which looks negative, where the ligand is only sticking into white matter, and it spares the gray matter where the amyloid lives. Here, this is where the amyloid lives. It lives on the outside of the brain, and in this case, this person has Alzheimer's by definition because they have a positive amyloid scan. We also can measure tau, and tau creeps in the brain, somebody who's mild, more moderate, and more severe. So amyloid is all over the brain, and tau is more intimately linked with the areas that become dysfunctional. This person has a little bit of memory loss, this person has memory and thinking problems, and this person has a visual variant of the disease where they can't see properly. This is the man who mistook his wife for a hat, if you're familiar with that from Oliver Sacks. We're also learning that amyloid is very complicated. So the causative protein for Alzheimer's disease itself is extremely complex. It's formed in these monomers, but they instantly bind into these balls and small strands called oligomers and protofibrils. And these things are particularly bad, and that's the target of a lot of the therapies. Over time, they cross-link into what we call fibrils and then the plaques, which are represented here. And this is what we're measuring with the PET scan. We're measuring more aggregated species with PET scans, but really it's kind of a marker of a marker, because these guys are what's probably driving the disease more than these guys, okay? What do oligomers look like? The bad things, they look like these little dots on electron microscopy, and there's a model of them, what they actually look like as they ball together and sort of send these like tendrils out. And here are these protofibrils that are these tiny little lines of amyloid, which then coalesce and polymerize like a plastic into these long strands of polymers. So again, amyloid, tau, neurodegeneration. That's the way it goes. Where we see amyloid, later we see tau biomarkers, and then that's intimately linked with memory and thinking problems and clinical function. Is really closer to tau, but that's just the way that this cartoon looks. So big news from about 2 years ago. There was going to be a meeting of the FDA to discuss an antibody that got rid of amyloid. And the background is really important. This is a monoclonal antibody against beta amyloid, and it looked so good in a very big phase 1 trial, like a hefty phase 1 trial, that the drug sponsor went directly into a phase 3 without really doing a firm dose finding study. It just looked too good, and they thought that they understood what they should do in a phase 3 trial. Unfortunately, they were wrong, because of their early errors with trial design and amendments that they wrote to change the trial a little bit, it looked like the data was going to be futile. So they were predicted statistically that the trial was going to result with no benefit. And when that happens, you're really obligated to stop the trial, because ethically it's not useful. So why expose people to any risk? So the 2 trials were halted. But then everybody came back for their last visit, and the analysis of blinded and not full, but fuller data set, as much as they were going to get, full is in terms of what they were able to get, showed that one of the trials had a 23% reduction in progression. So pretty good. And the other trial was totally negative. One trial was actually trending positive when they declared futility. So it's basically like the mistake of, I mean, the century. A huge screw up.
She'll appreciate it.
Everyone kind of mute your phone, your computers, okay?
Oh yeah, it's been a long time.
So now the data is limited. The trials are not complete. Biogen discussed this matter with the FDA, and they submitted. And by the way, that's John Bolton looking at hanging Chad with Gore versus Bush. I mean, this data is scrutinized to the hilt.
In 5 years.
And they wanted to understand why the negative trial was negative and the positive trial was positive. These are the placebo people. Folks on the higher dose of the drug did better. And here there was essentially no difference. And one of the reasons immediately is that they cleared less amyloid. The negative trial, negative here, cleared less amyloid. Less bad stuff got removed, and they didn't do as well. The folks who really removed amyloid robustly past a certain point had better cognitive outcomes, better functional outcomes. There's also a side effect of this drug. So About a third of the people had what we call vasogenic edema, or now called amyloid-related imaging abnormality, or ARIA. What happens here is that amyloid gets into little tiny vessels. We don't know exactly why this happens, but when we remove the amyloid, it makes the vessels leaky, allowing fluid and sometimes blood to get into the brain. And this is what it looks like on MRI. So this person has normal brain tissue over here and abnormal brain tissue over here, because MRI is really good at picking up water in the brain, because the brain is mostly composed of fat. That water really looks weird to an MRI. And so that's what we see here. We see the leaky vessels, kind of allowing water to get into the brain. And so the entire brain kind of on this side looks swollen versus this side. This patient very well could be asymptomatic, okay? It's weird. A lot of radiographic looking ARIA does not have any clinical correlate. It's just sort of a sign of getting rid of amyloid, really. But it is a fear, and it's very present in people who are homozygous for the gene that is a big risk factor for Alzheimer's disease. So these people are a little bit genetically cursed, but having both a genetic risk factor for the disease, and they also have a risk factor for the side effect of the wave of therapies, okay? So it's about 15% of any trial, and 2% of us have the 2 copies that put us at extreme risk of the disease. So if 2% of the population, you see what a big risk factor it is if 15% of a study has those genes. And of those people, about 2/3 get the brain swelling versus about a third who have 1 copy versus about 20% who have no copies. So it's a big risk factor for this brain swelling. Here's a case. He's a neurologist. He noted he had olfactory impairment. He couldn't smell anything at the age of 55. Now this is COVID, okay? Who's lost their sense of smell to COVID? I have. Lots of people have. But before COVID, if you typed a Google search for "I've lost my sense of smell" into Google, you're going to get Parkinson's, because it's a prodrome for Parkinson's. And that's kind of what he thought he was destined to get. He didn't recognize that it can also be a prodrome to Alzheimer's disease. And he started getting mild memory loss in his early 60s. A year later, he retired from neurology, and he joined in an observational study at first, but then he got into the ADU trial, where he was given placebo for 1.5 years. The drug failed. It was deemed futile. But then they opened it up, and he got the stuff in open label. So he got the real stuff in the open label study, and he quickly got ARIA. 4 doses in, 1 titration, he gets 2 titrations, he gets brain swelling. So this is what his brain looked like. And he had his clinical phenomenon. This is not asymptomatic. He had a lot of symptoms: explosive headaches, fluctuating confusions. He went to the emergency room with a systolic blood pressure of 206. That's extremely high. He was discharged to home, and basically he had this really bad ARIA. That's what he looks like. And then Medicare met, and they looked at all this data, and they basically said, no, it may work, but
that's just
you're not going to cover it. So it kind of reminds me of this cartoon, Thursday's out, how about never, is never good for you. And that happened just this year. So they are completely refusing to cover this drug, despite the FDA giving it accelerated approval. So more on that later. Medicare met and did not approve the drug despite a phase 2 trial. And we happened to help conduct it, but this phase 2 trial showed exactly what the positive trial for aducanumab showed. It's a different drug, but it shows exactly the same stuff. A slowing in clinical progression, where you can see that the people on the drug do better, and really robust removal of amyloid. So it does pretty much the same thing, and it really put some wind into the sails, but Medicare was not buying it. It actually, if you read their initial memo, that's what they were calling their report, where they denied it, they didn't even mention this trial. It didn't even pop up on their radar, among with a lot of other specious reasoning. And again, more on that later. We had already known that a third drug called lecanemab in 2017 was positive, showing pretty much the same thing, robust clearance of amyloid in green, the dose finding study, but don't pay attention to that. Just pay attention to the green. The higher dose people did well in terms of clearing amyloid, and that was correlated with a little bit of slowing by 30% on clinical testing, on day-to-day function. And that's what we just saw with their phase 3. So that drug, lecanemab, has had a positive phase 2 and now a positive phase 3. And I just put this in because I was there, and I'm going to brag about being part of this like wonderful event a couple weeks ago, where we saw this data really play out just so beautifully, exactly what you want to see, which is an almost immediate separation on this measurement of function. And the placebo people didn't do quite as well, and kind of ignore this part because the metric is hard to figure out, but it delayed progression by 5.3 months, okay? So if you get to this arbitrary point on placebo, we can spread that out over about 5 months in a year and a half, okay? A 30% increase in time, okay? And of course, it was robustly positive, showing exactly the same thing, robustly reducing amyloid right off the bat with sustained reduction in amyloid. It's exactly what we see here with, if you just pay attention to the positive trial, which is not fair, but bear with me. Positive trial, robust reduction in amyloid. It correlates with about a 30%, 20 to 30% reduction in progression. We've also learned from negative trials. Every negative trial that we've done has had a reduction in amyloid that is not sufficient. We were doing these trials as well, gantenerumab, and they failed. They failed, but they were trending in the right direction, where the people did a little bit better, 6 and 8% better, but not much. And you see that with better reduction of amyloid on PET scan, you have positive trials. And the threshold is obviously below 25. And here it's above 34. So let's call it like anything above 30 in the 20s works. Anything above 30s is not working. And again, like 1 is sort of one-off, 2 is coincidence, and now we have way more of a pattern, okay? So this is not chance alone. It's just lining up so that with reduction of amyloid, you have positive study. With not as much reduction in amyloid, negative study. And this is really complicated. I just put it out there. This is getting better down here clinically, and this is removing amyloid on the x-axis. Drugs that don't work are in here. They don't remove amyloid. Drugs that work are down here. And what does it show? Other than this really weird one from the negative trial of aducanumab, the trend is really clear. The more amyloid you reduce, the better off patients do, okay? So when we put them all together, we really reduce amyloid, and that is paired with clinical improvement relative to placebo, slowing of the disease. So the bottom line is the FDA gave accelerated approval, meaning the FDA judged this works to remove amyloid as a surrogate biomarker. And that biomarker is reasonably likely to mean it works. And so there are 3 drugs in the class that are similar. And in oncology, this happens all the time. I mean, who here has seen an advertisement for Keytruda? Keytruda has had a bunch of accelerated approvals that Medicare is currently paying for, but they're not paying for aducanumab. Medicare is not paying for it. Why? They didn't really explain the reasoning well, frankly. And so that's a call to arms. They're going to have to cover lecanemab, but it's going to take a long time for that to get out and running. And I would equate it to financial fraud, because folks who had Alzheimer's disease paid into Medicare all of their life, and now they don't get a drug covered that is reasonable to cover their disease. And so considering the new data, the coverage decision really should be reconsidered. And of course, Medicare is never going to have that because it's government and they're big and they don't really have to answer to anybody except their bosses. More on that in a sec. And I would just put in, this is really bad for the future, because investment in Alzheimer's disease, even though there's a lot of excitement among researchers, finance people, they're not dumb. They're managing other people's money. What are they going to invest in? Okay, are they going to invest in cancer? Are they going to invest in a Harry Potter movie? Or are they going to invest in aducanumab or another Alzheimer therapy? Medicare puts up another roadblock, not just the FDA roadblock, but a Medicare only roadblock. Then, funding dries up. And we've actually seen some of that. So these are the people to talk to. Senator Casey, that's his number, that's his Washington number. And he's still around, okay? And this guy currently is a quiet quitter, okay? I wrote to him and I just got like a complete form letter about the importance of the market and blah, blah, blah. But, he'll be replaced by Fetterman. And Fetterman, he is very aware of brain diseases. So perhaps he will be a sympathetic ear for this Medicare debacle. The work goes on. So even though I said funding is sort of diminished, it's going to headwinds. We are continuing to do these clinical trials. I've circled the ones that are in development that we're doing. And as you see, there are many, many, many others, some of which are good shots on goal, and others are kind of like, oh boy, I don't think grapeseed extract is going to work, but hey, you know what? Someone's funding it. And that's it. That's where we live. This is our office right through those doors. And I am actually currently speaking to you from this window right here. Okay. So drop on by with any memory concerns. So let's take it to the chat and see what is going on. Mute computers. Okay, please. Yes, I think that happened. Now take yourself off, unmute, and ask questions. If you want. It's kind of like an open conversation. But I've definitely.
If you have any questions, you could enter it in the chat.
Is it in the productivity computers? Probably, right?
Don't be shy, guys. Okay. Do you do any other genetic tests like APP or presenilin? So the presenilin is very rare. And let me just go back to the slide where it's relevant. One of the reasons why we know that Alzheimer's disease causes, or I'm sorry, Jesus. One of the reasons we know that amyloid causes Alzheimer's disease is because these very rare people, it's about 1 in 100 people with Alzheimer's disease, and about 10% of those under 65 have a very rare mutation here where they're very good at cutting out amyloid. So if you're good at making that amyloid fragment, then you get an increased load of amyloid throughout your life. And people like that typically present with Alzheimer's disease in their 50s, okay? So it is very unusual, and I sort of recommend against testing that, except in very unusual circumstances where someone is, really cognizant of changing their life, because having that gene entails that you are going to get the disease. So it's like Huntington's disease. You're going to get this disease if you live long enough. Okay. So other genetic questions, genetic testing in the practice, absolutely, because to consider aducanumab, you have to make an informed decision, okay? And here is the information. If you're homozygous, you have 2/3 chance of getting brain swelling on this drug. Lecanemab, much less risk. It's about 35%, 1/3, okay? If you're homozygous. So you see the spread, it's 2/3 versus 20%. You should really know what you're getting into and what your risk is before you make the decision to do it or not. And that's just a conversation, okay? So 2 years ago, I would have said, no, don't bother with genetic testing. Now I say yes, but don't go out at 23andMe. That's not a good deal because they store your data and God knows where they're selling it, who they're selling it to. Okay, what about trials to remove or break up tau? Well, that is here, and we definitely skimmed by it. So mechanism of action, amyloid, as you see, a lot of red dots and a lot of tau, a lot of blue dots as well. The blue dots, either, they're looking for people with mild modic dementia or prodromal disease. It's been harder. They have also met with a lot of failures. There used to be a ton of phase 2 trials. They did not work with antibodies against tau. So, yes, they do exist. Okay, when is it appropriate to get a PET scan? Well, okay, Medicare is not paying for PET scans, so they're about $3,500 right now. You have to pay for the ligand, you have to pay for the scan time, you got to pay for the expertise of the people who are giving you the ligand. So it's appropriate to get a PET scan if you get into a trial, because then it's either positive you get into the trial, negative you do not, because there's no target. We can evaluate the protein from a spinal tap, a lumbar puncture, and Medicare is paying for those. And same thing. So LP positive, you get the drug, but negative, there's no target. So no biologic target. You could still have the appearance of Alzheimer's disease, but it's probably due to a different protein. So it's appropriate in consideration of these disease-modifying therapies or within the setting of a trial. Are all these medications for early Alzheimer's only? No. So you see well, I mean, basically, yes. The current disease-modifying therapies, these guys, yes, they were all studied in extremely early people. No, this drug is not related to any of the drugs I've discussed before. Yeah, so this is a tough question. Rejected from trials because of an old bleed. No proof that bleeding is caused by existing amyloid. Any chance of getting a trial now? I think that's more of a private question. It's definitely not a good fit for these monoclonal antibodies, because having an old bleed may indicate that you have increased susceptibility to getting that brain swelling. and that would not be safe. So probably not those, but each case is individual, and if we're bleeding on the outside of the brain, it's hard to say. I would just say, happy to see you. Could you explain the difference between positive and negative outcomes in clinical trial, as well as how people on placebo could have any improvement in trial? Well, in these situations, we did not see any improvement in placebo. Now, there's something called the placebo effect, and it's very robust. Okay, the mind and the brain are powerful things. I think we've all experienced that. If we have a headache but want to do something, we just sort of power through it, and all of a sudden we get distracted. The headache isn't bothering us, the pain isn't bothering us, the whatever is not as intrusive. But in these diseases, we're really not seeing much of a placebo effect, if any. So positive and negative trials, this is it. Here's a positive trial. The people on the high dose aducanumab did better on this metric. People on placebo worsened more. I mean, that's as good as it gets. I guess it got a lot better when we saw this one. Very clean, nice lines with very narrow bars. The placebo people did worse, and people on the drug, in this case lecanemab, did better. Does CRISPR offer any therapeutic to alter a gene? Well, it is currently, provocative. I think that it's a long shot. So people with ApoE4 have had that gene all of their life. So to modify the disease over a course of a year and a half by changing your ApoE4 to a 2 or something, that's a long shot. But, it's basically another inquiry, keep inquiry alive. Sure. But, there's a lot of weird promises about CRISPR. It hasn't helped many people. I mean, we'll see what happens. We'll see in the future. But this may be a time for like 2040. Okay, like literally that's how long this would take before CRISPR is approved or gets into a trial. I mean, there's so much preclinical data to make sure it's safe, and the CRISPR, which is genetically modifying cells, isn't genetically modifying them to do something bad, like get cancer. Oh, host isn't allowed. That's beyond my skill. Did Biogen stop manufacturing? No, Biogen did not stop manufacturing aducanumab. So they're still doing it. I mean, they're still making it. It is still available. It costs about $20,000 for the first year. Do you have any trials for non-symptomatic individuals with a parent diagnosed with Alzheimer's disease? Yes. So there are preventative trials. So in the preventative space, they're using actually this drug in the prevention space, where people are building up amyloid years before the onset of any memory problems to try to head off memory in the prevention. So yes, that is called the AHEAD study, and you can look it up. AHEAD, like ahead. Are other countries like Canada more likely to make these potential drugs available and affordable for early Alzheimer's disease patients? No, absolutely not. In fact, the European Union, no, they've completely washed their hands of this. We'll see what they do with lecanemab. England, no way. I mean, the National Health Service currently cannot do much. They are completely overwhelmed in that nation. So in terms of Canada, I don't know about them as much, but no, they are not more likely. In fact, I would say that they're much less likely. The main market for pharmaceutical folks to recoup the expense of clinical trials is America. And I don't know the story about Canada and aducanumab. I do not know. There's no covered AD medication point at this point. What's the advantage of early detection? Clinical trial. So there's no covered medication at this point. That's true. So there is no advantage to early detection except for disclosure of what's happening. So I actually find that we can kind of take a lot of toxicity out of family members and relationships and dynamics just by disclosing that this is not their fault. Okay, the person who is being affected by memory loss isn't putting it on, it's not volitional, it's due to a disease, and that sort of like lets everyone calm down a little bit and kind of like not put kid gloves on, not walk on eggshells. That we call it the gray veil that comes over people when we treat people like differently because they have this disease, which I think Medicare did, if I can just put that in there, you know, putting people in this kind of wastebasket of, oh, you're gray veil. Sorry, if you had cancer, we'd cover it, but Alzheimer's, you know, call me never. But I do think there's an advantage just in terms of social interaction. And also, we do have some symptomatic medications that may not be approved, like sertraline or antidepressants that can be used to take the edge off what we call neuropsychiatric problems. And there are some medications, again, purely symptomatic that just boost memory called donepezil, Aricept, and the like, and that can help. What makes a determination of moving from MCI to Alzheimer's disease? So people with mild cognitive impairment have memory loss that is mild, and based on the totality of the evidence, do not have a dementia yet. So they haven't had the memory significantly affect day-to-day functions. It's sort of in the judgment of the person that they're sitting across from. So the determination is basically somebody with mild cognitive impairment has memory loss that does not impair function. People with Alzheimer's disease have memory impairment and another cognitive problem like language, visual spatial problems, dysexecutive stuff, can't figure stuff out, judgment, and then their condition is also affecting their day-to-day function. So that's kind of separate, but because it's a continuum of a disease, it's sort of like, when did dusk become night? You know, everyone would kind of have a different judgment exactly at the time that dusk became nighttime. All right. Will amyloid plaque return after aducanumab treatment? That's a great question. And the answer is maybe. We really don't have long-term data from withdrawing these drugs. There is lecanemab data where they did a withdrawal study, and people actually then worsened in parallel with this drug, lecanemab, before they got on open label. So they were probably getting not amyloid plaque, but they were probably developing these guys. Okay, so they didn't fully clear all these oligomers and protofibrils away, but what we measure would become negative and negative-ish. We now have some pathology on these people, and they don't completely go away, but they're very much reduced, almost imperceptible. And so basically, yes, the amyloid, when not treated with the current medications, there may be that third one, lecanemab. That may be a different story because Lilly is really devoted to 6-month or 1-year treatment and then stopping it. But basically, amyloid plaque may not return, but people could develop more amyloid species on the soluble or like not as big forms. I was diagnosed with Alzheimer's for 2 years. Well, you can call the office. I can just type in the office number here. So this is our office number, which I just sent in. Oh, you know what? I'm sorry. Somehow it went to I'm going to put the office number so everyone can get the office number. 9250. Okay, that's everyone. Something that's coming out in 2023 that looks promising. That is lecanemab. Okay, I can't talk about eligibility, but you know, I'm here. I walk right in. Okay. Okay, thanks. Moderate Alzheimer's treatment. Yeah, it's the word. How can I say this? The current drugs are really focused on early disease, and early disease is defined based on clinician impression. I mean, someone can be testing pretty low-ish on cognitive testing, but that may be because they have a language problem, okay? No one with this disease is disposable, okay? There's dignity in something we can do regardless of the stage of the disease. So we're not giving up on anybody, but at the same time, the trials are really focused on people with very early disease. So in terms of more moderate treatment, you know, I think it's just an open conversation about where to go and what's happening, and you know, maybe there are other fish to fry that we can make better. It's a tough question, especially because, well, it's sort of vague, but you know, we have things to do. I have a policy that we can always help, and maybe that help is just a kind word or something better to do with day-to-day activities. We can always do something. Someone very helpfully said the Delaware Valley Alzheimer's Association, that is their 24/7 helpline. Stem cells. No. Basically, the answer is no for that. Stem cells, in this, you got to be really careful because there's a lot of quackery out there of people using stem cells, which are total nonsense. And they're just basically taking like fat cells and inject them into random areas and then calling it a therapy, but it's never been approved. And it's just like, you know, there's a bunch of quacks out there, not just Mehmet Oz, who's been abhorrent about this, but also watch out for Bredesen. He's particularly problematic. He publishes because it's not really it's a predatory journal where you basically pay to publish these case series where people have miraculous cures, basically based on his assessment of micronutrients and all this other total nonsense. And so he wrote The End of Alzheimer's Disease, which kind of tell you exactly what he's about, which is buy my book, I want your money. Perlmutter as well is another sort of like black sheep, horrible person. So watch out for stem cells. The other thing about stem cells is that there are trials using stem cells, but they're in very early development. And in here, there's really no way to rewire the brain, and you really wouldn't be doing anything for amyloid anyway. So stem cells probably not only not ready for prime time, but we'll probably never see any utility in stem cells. I don't see any more messages, so I think that wraps it up. I did send the phone number, our phone number for the office for any sort of direct, more private conversations, because I think that's what some of this really takes, okay? In recap, everybody, please call your senators and watch out when Fetterman takes office. Again, he has had a brain problem. He's been pretty public about it. This guy's a temp. You know, he has senioritis. He's going to be out. So call these people. Call and write to, you know, Robert Casey and Fetterman, and really make your voices heard, because we live in a democracy. Medicare, unelected officials, they're hiding right now, and they've been silent, absolutely silent about an error. And that, up to me, is particularly abhorrent because look, anyone can screw up. Every day, I tell my staff, I hope we're listening, you don't want to screw up, don't show up at work, okay? That's not the issue. Screw ups happen, errors happen. It's what we do next. It's how we pick ourselves up and move forward. Medicare is not engaging with this. They're not engaging with the error. The process cannot improve unless we pick up the phone and really light a fire. So thank you, everyone. Great talking to you. And hopefully I'll see you in the office or on the street. And other than that, happy holidays. Best to everyone.